What is the definition of shock?
Poor perfusion and tissue perfusion.
That's right. Piss, poor perfusion. Or poor tissue perfusion. Most notably to the brain, but really to all the tissues. Okay? So there are 3 stages of shock. What's the first stage? So compensated is first. So that makes sense, but according to the American Heart Association, also makes sense. Hypo.
Tension, of course.
Intensive.
Last one.
Decompensated.
Now this is decompetence.
Irreversible.
Irreversible. Dead. Okay? So once you get here, there's no turning your body around, you're dead. Okay? So tell me some symptoms of shock. So go ahead, this group, give me one.
Mottled skin.
What'd you say?
Mottled skin.
Mottled skin, okay? So skin signs. Group back there, give me a symptom of shock. Great. What else happens with the respiratory rate? Okay. Next group in the back. Tachypnea. Okay, got that. Give me another one. All right, you guys give me one.
ALOC.
All right, so that's going to be early, right? ALOC is going to be an early sign because we're talking about decreased blood flow to the brain. And the brain is dependent on every single beat that comes to it. It can't store any oxygen at all. Or, sorry, well, glucose or oxygen. So it is dependent on each heartbeat. So other parts of the body can store sugar and other things, not oxygen, but it can store sugar. So it can last a little longer, but the brain is dependent on every single beat. That's why this is one of the first things to change when we have a decrease in perfusion or blood sugar or hypoxia, right? This is one of the first things to show up before anything else because it's literally takes seconds to very few minutes in order for the brain to start showing problems. Irritability is the first one to show up. So if they start getting cranky, antsy, please check sugar and oxygen and think about perfusion, okay? All right, what else? We need one more over here. Back group.
What's that?
We need one more symptom of shock. Phone a friend? There's like 30.
Cap refill.
Okay, great, cap refill. Great. So, cap refill on a kid, what should cap refill be on a kid?
Less than 5 seconds.
Less than 2.
2 or less. Okay, so pick a way to remember this. Adults are less than 4 seconds or 3 or less. Okay, and kids are less than 3 seconds or 2 or less. So think of 2 for kids and 3 for adults, or less than 4 for adults, less than 3 for kids. So figure out whichever way works for you. All right. So I know. So for kids, 2 seconds or less. That is normal, okay? So this, for a sign of shock, it'd be 3 or more seconds. For adults, it'd be 4 or more seconds is abnormal, okay?
You just talking about kids today?
Well, yes, it's true. It's true. Okay, so any other ones? I heard a bunch of people yell things out.
Irritability.
Okay, that's up there, but I'll add it as its own because it's so important. Any other ones?
Blood pressure.
So I wrote skin, but somebody actually said mottled, so tell me some more on the skin. Okay.
Not diaphoretic.
Clammy, cool, clammy, that kind of stuff. Fantastic. Great. Now I did hear blood pressure. So those are all compensated shock. What is the blood pressure on this side? Normal BP. Awesome. So for an adult, what's normal BP? What's the low end of normal for us?
100.
Great. 100, 90 maybe, but 100 is what I would say there. What is this for children?
70 plus age times 2.
Woo! Thank you. 70 plus their age in years times 2. Awesome. So we have that. Let's talk about what a 2-year-old, what is the lowest acceptable blood pressure? That's not their normal blood pressure, but it's the lowest acceptable blood pressure to say they're not decompensating. They're not over here. Okay, so they're getting perfusion to their brain. Great. So 2 times 2, 4 plus 70. So 74. This is the lowest acceptable, not normal. What about a 5-year-old?
80.
Great. What about an 8-year-old?
You gotta put brackets around the 2. 96. Your bracket's in the wrong spot.
Shit, who's this math expert?
No, not there. No, the other one to the left before age.
You technically don't have to do any
You
brackets.
messed it up. The bracket has to be before age.
Come on over. Fix it. I don't have any idea what you're
On the 70 plus, you gotta go back before the A in age. Erase that one right above your pen.
None of this matters.
We're keeping your seat warm. Now bracket the whole thing. Nope, the whole.
There you go.
No, there you go.
Who is this math nerd?
That's
All
me.
right, super. Thank you for the math because I can't do the math.
It
All right,
matters.
80. It does matter, actually. It really does. Not for us right now, this moment, but it does.
Details matter.
86. That doesn't matter.
86.
96.
Whatever it is.
8 times 2 is 16.
Plus 76.
86.
Are we happy? Agreed on this? Awesome. What about a 9-month-old?
Age in years.
How many years? How many years have they been alive?
0.
0.
12 or 9 plus 72.
Okay, 0. What about a 12-year-old? 90, exactly. Why'd you say that? Because that math doesn't work. Right, we're not going to make a kid be higher than an adult, right? So basically, this starts at 10. So 10 to 110, basically we're saying 90 is the lowest. That is perfusing their brain, not the normal, but the lowest that we think they're perfusing their brain. Yes? Great. So what about a newborn? 60. That's up to 28 days old. All right, fantastic. So here on this side, basically we have all of these symptoms getting worse and we're hypotensive, right? So we're below these numbers here. Okay, so we have hypotension, low blood pressure. Everybody understand what I'm saying there?
Yeah.
Okay, so if you are 5 years old and you're 78 and you're showing any of these signs, you are in hypotensive shock. Okay? If you show these signs but your blood pressure as a 5-year-old is 80, you're compensating. Yes?
Yes.
Okay. Or anything above 80. Okay, so all this stuff, this gets worse and the blood pressure drops. So over here, in compensated, you're compensating for all this crap here by normalizing your own blood pressure. Your body is still healthy enough to clamp down and create a decent blood pressure. Here you're getting too sick to clamp down and compensate with that blood pressure. And then irreversible, you're just dead. Okay, so now we're going to come back and say that there are 4 types of shock. So what are the 4 main types of shock? Okay,
Cardiogenic.
awesome.
Distributed.
Yep. One more.
Obstructive.
Hypovolemic, it splits again to 2 different types of hypovolemia. What are the 2 different types of hypovolemia? How do you get there? How do you get to hypovolemia? Fluid loss, right? So I got 2 types of fluid that I might not have. Blood and other fluids, right? So I either lost the blood from hemorrhagic shock or non-hemorrhagic shock. So what would non-hemorrhagic shock look like? How do we get non-hemorrhagic shock? Dehydration, pee, poop, puke, right? and not taking it in. So pee, poop, and puke, or not taking it in. So we're in a dehydrated state. And then how do we die, or how do we get into hemorrhagic hypovolemic shock? 2 ways.
Breaking the container.
All right, where?
Anywhere.
Or outside.
Inside or outside, yep. So internal or external. Where are the 4 places that you can bleed out within the body? 4 body cavities. Pelvic, abdominal.
Retroperitoneal.
I'm gonna consider all that. Actually, no, they are different. Pelvic, abdominal.
Retroperitoneal.
Usually you can't bleed to death in the retroperitoneal.
Thoracic.
Thoracic cavity.
Brain.
Skull. Femur.
Can you bleed to death from hypovolemia in the brain?
Unlikely.
Rectum.
So femur, right? You can bleed to death in the femur. So femur, pelvis, abdominal cavity, and the chest. And there's one more actually, which is onto the pavement. Okay, that's not inside the body, but you can bleed out onto the pavement. All right, so that's that. How do we, so the problem here, if we think about the 3 different systems we have the pipes, we have the fluid inside the pipes, and we have a pump to pump the fluid around the body, right? So those are the 3 issues. So in hypovolemic shock, what's the issue? Not enough fluid, right? So how do we fix it?
Add fluid.
Give them fluids. How much fluid do we get?
20 mgs per kg.
20 milliliters per kilogram. Okay, that's our starting bolus. How fast do we give that?
Rapid. Depends on
Rapid. Yep. So in this situation, 10 minutes. Okay, so don't get mad about my parentheses, okay? It's a different setup here. It's grammar now. 20 milliliters per kilogram, fast. Second bolus if they need it, so we reassess them, right? We're always gonna listen to lungs first before we run a fluid bolus on everybody. So we're gonna run the fluid bolus, and then we're gonna reevaluate all of this and vital signs, right? And then we decide if we need another fluid bolus. How much would the second fluid bolus be on a hypovolemic shock? Same. Now, you need to give blood at some point, right? That's what they need. Saline has no oxygen carrying capacity and it has no sugar in it. So as we start to fluid overload these kids and give them a bunch of fluid, they're gonna become mostly water, right? Mostly saline. So we need to think about that. By the time, I'm not going to do the math here, but by the time we are at our second fluid bolus, we are getting close to half of the child's circulating volume being saline. Okay? That's a problem. So we've got to get blood, and that whole blood by medics is a whole nother topic. It will be here someday, but it's not here yet for you guys. In this area, I'm sure they're doing it down in SAC, but I'm not positive. But in the Nevada side, they are doing research in Clark County. And so they are running trials with pre-hospital blood. What about epi, push dose epi? If we can't get the fluid, if we can't get the blood pressure to come up, we've given 2 fluid boluses. We're starting our 3rd fluid bolus. Can this guy have push dose epi as our vasopressor? Or a vasopressor in general? Yeah. They can. Now, a lot of the protocols say if it's hypovolemic shock, no epinephrine, but the current research is they're bleeding to death. Let's do something to get blood flow to the brain, okay? I don't know what your protocol is off the top of my head. Good on that one? All right, let's do cardiogenic shock. So cardiogenic shock, what is the problem? The pump. So it's actually the cells of the heart are not acting right. Okay, so for some reason the heart can pump except the cells aren't working, so therefore it doesn't pump. What are some reasons these cells would not pump?
Imbalances in blood.
Like electrolyte imbalance. Okay.
Congenital.
Overdose, which would be one of the same, really.
They're gonna, if they overdose on what?
Calcium channel block.
Okay, cool. So then we have a dysrhythmia, like ... The overdose causes a dysrhythmia, which causes these cells not to pump appropriately, right? We have a weird rhythm. So bradycardia, tachycardia, heart attack, MI, right? that kind of stuff. So the cells are not CHF.
CHF.
Yep, CHF, super. So in all those situations, and that's more adult stuff, but kids can have CHF type presentations, but that's cardiogenic shock. So I don't have flow because the pump is weak, right? And so if the pump is weak, where does the fluid back up to? Legs, lungs, and liver, right? Depending on which side of the heart's not working. So fluid is backing up. So what do the lungs sound like in cardiogenic shock?
Rails.
Great. So think of cardiogenic shock as CHF on steroids, basically. CHF where you are looking real bad and we're losing cardiovascular performance. So in this situation, we have fluid backing up, right, and into the legs, lungs, and liver. So I get wet lungs, and I get puffy legs. Okay, edema in the legs, pitting edema. So what are we going to do for them? Pull the fluid off. How can you do that?
Diuretic.
Okay, at the hospital, right? So we're going to get Lasix to pull off that extra fluid.
Insert an expert consultation.
All right, that's down here. There are some things that you can do.
Fix the pump.
Okay, how do you fix the pump?
Electricity.
It's either mechanical.
Okay, possibly electricity. I'll give you that.
Vasopressor.
That's right. So we need a vasopressor to squeeze down, and really what we need is a positive inotrope, okay? So it's not a vasopressor, although that's part of it because their blood pressure's in the toilet. Positive inotrope. What is a positive inotrope? What's that mean?
Dopamine.
Okay,
You're gonna whip the
but what does inotrope? What is squeeze?
Contractility.
We are making the squeeze stronger. So that's what we need. What med do you have that, spoiler alert, is both of those? Epi. So push dose epi is what we're doing for this guy. Now, I always say you can't give push dose epi until you've started your second fluid bolus. You got to fill the tank before you can start squeezing more, right? So are we giving this guy fluid? Cardiogenic shock, backed up, extra fluid backing up.
No.
You are. So you're giving fluid 5 to 10 milliliters per kilogram over
2 minutes, 40 minutes.
20 to 30 minutes. So what I say here is low and slow. Okay? So this guy's problem is fluid. I'm putting it in there fast. This one, if I give too much fluid, I'm going to make him worse, right? His pulse ox is going to drop. His respiratory effort is going to go up. So this guy, low and slow. So low amount, 1/4 to 1/2 a normal, and slow, 2 to 3 times the length of time it would take to normally go in. You've already listened to the lungs for sure, and you're going to be listening to the lungs probably every 10 or 15 minutes to make sure you don't need to turn it down or off. Yes?
Yes.
Yes. All right. That's basically that one. Obstructive shock. What's the problem?
Something's distribution.
Right. The problem here is actual flow throughout the body, right? But blood doesn't flow this way, but it goes. So we have a problem with the flow. Somewhere in the flow, we have a blockage. So what are the main things that cause a blockage in the flow for blood to be able to get around, pick up oxygen, give off carbon dioxide, all those things? Tension pneumo, great. How do we fix a tension pneumo? Needle decompression, awesome. So what might the lungs sound like on the tension pneumo side?
Absent.
Diminished.
Might be none and might be diminished. So don't be fooled. I had a friend who did not needle decompress on the side of the road out in rural Nevada because he heard breath sounds. Total mechanism, looking like shit, but heard breath sounds, and it tricked him out of it, and he didn't needle decompress.
You gotta go by other signs.
Exactly. So you may, right, you could be a pneumo here, but still be moving one of these other lobes. We have multiple lobes in our lungs. So don't be fooled by that. Okay, so tension pneumo, we're gonna needle dart them, and hopefully, how soon should we be seeing an improvement? Right away, because I have that pressure coming down on the heart, so the heart muscle itself can't beat, right, because of the pressure of the lung pushing over. So a regular pneumothorax does not need needle decompress. That just means that there's a lobe that is collapsed. That's all it means. Shortness of breath, sure, maybe some pain, sure, but they're not decompensating. When they're decompensating, it's because that pressure is pushing so hard that the heart cannot do its thing. It's obstructed from squeezing. We've got to release that pressure. As soon as we release the pressure, the heart can now pump properly. Yeah? All right, what else?
Tamponade.
Super, so tamponade is basically the same thing. How do you get tamponade? What's the main reason?
Trauma.
Blood force trauma. Blood force trauma to the chest, the steering wheel, the fall to the ground, whatever. So this, we have the pericardial sac, right? That's around the heart. There's a little bit of fluid in there. And we have these vessels on the outside of the heart, right? And so if I have blood force trauma and one of these starts to leak, I'm leaking fluid in here and this is starting to get bigger and bigger and bigger. All it takes on an adult is 50 extra milliliters of blood in here to cause tamponade. That's not much at all if you have a bleeder. So all that blood is pushing down on the heart, and so it's the same thing. The heart cannot squeeze, therefore no pumping, therefore no perfusion. So we're going in here with a needle, a pericardiocentesis. So driving a needle up underneath the sternum with an ultrasound. You guys are not in the hospital, someday maybe. You're driving a needle up here into right here, okay? Literally that's about the length of the needle. It's a 60 cc syringe. So I'm putting that needle right up in there. I'm pulling off 50 milliliters at least. I need to keep some in there. What does the little bit that's in there do? Lubricates, right? So I don't have any friction when I'm pumping. So I'm gonna pull about 50 milliliters off. I just released this tension and now the heart can start pumping again. So minutes.
So then when that happens, don't they have to go in and stop the bleeding?
Great question. So if I didn't fix the bleeder, it's gonna keep happening. So I'm gonna keep pulling this off to keep the dude alive. He's going to the OR.
Yeah.
Yeah, he's going for open heart surgery. We just had, somebody just told me about one of these. The medic stayed in the ER to watch the pericardiocentesis, which rad, right? And so and this was Carson Fire, I'm pretty sure, and they could see they're practicing with their ultrasound. And so they, big novice, but they could see that the heart was enlarged. So they kind of knew what it was, plus he looks like shit. When they got in there, the doc confirmed it was tamponade and set up to do the pericardiocentesis instantly. Pulled this off, dude looked great. He started looking good again, so he's like over here, looking pretty good. And then after a couple minutes, he's here again because the bleeder was still going on from I don't know what he was bleeding from. But,
Are they
so it's just
cauterizing?
gonna keep, no, well, I don't know what they do in the OR. Honestly, I have no
Do
idea.
flight nurses still do this? Because I know they used to.
Probably with ultrasound. It's not that hard of a procedure. You got an ultrasound. You can see you got a massive target there,
Where are they going from?
underneath the sternum. With the needle's about this long. Super rad. Okay. Any other ones here?
PE.
PE, fantastic. Do children get PEs?
Rarely.
So since COVID or COVID vaccines, I don't know which one, children are getting PEs, okay? Also remember that the 12 or 13-year-old girl who's on birth control and smokes cigarettes, high risk for PE also, okay? On yours there, your sheets there, any other obstructive shock ones for children?
Ductal dependent outflow obstruction.
Fantastic. I have no idea what that is.
It just says it right.
Ductal defects. This is congenital business, right? But you can see how blood's not going in the right direction. We got problems. Other things that can cause obstructive shock are an MI. And I don't know exactly how it leads to obstructive shock, to be honest, but on the adult list it is there. But these three I would say, are the main ones for sure. Okay, distributive. So in distributive shock, what is the problem? Sorry, I just erased that. What's the problem?
Container.
The container. So the vessels normally,
They go flaccid.
that's right. So I got blood in here, right? 3 things happen in distributive shock. So the fluids are distributed into the wrong place. So why do the vessels get floppy?
A neurogenic issue.
Okay, actually, thank you for that. There are 3 types of distributive shock. What are the 3 subtypes of distributive shock?
That's one of them.
Septic, I'll give you neurogenic shock,
Anaphylactic.
anaphylactic. So neurogenic started in the nervous system. We'll talk about this in a minute versus spinal shock. Well, I'll do those in a second, okay? So septic shock, anaphylaxis, and neurogenic. So here's our normal blood vessel, and we got floppy, but how did we get floppy? How did we get soft blood or soft vessels?
Reaction.
Dilation, exactly. So problem number 1, I dilate out, okay? So now there's what it looks like. So if I have this, if I was back here, I have fluid in a hose that has clamped on both ends. I have fluid in the hose there. What's that hose gonna feel like from the outside? Can you close that?
Yeah.
Thank you. Hard, tight, right? Tight, there's pressure in there. But if I put that same amount of fluid in a fire hose, what's the fire hose gonna feel like? Flimsy, right? Because I have all this space I can squeeze. All right, so I widen out. So I have the shirt on right here, can't see through it. But if I stretch it out, now maybe you can start to see through it. You see what I'm saying? Maybe this shirt doesn't do it. So as I stretch out, I become permeable, right? Like this. So now my vessels just became permeable because of the stretching out. So now I have wide floppy vessels. I have increased permeability. And the third thing, super important, anybody have ITLS? Anybody take ITLS? So this right here is called relative hypovolemia. It's not true hypovolemia. This person does have enough fluid in their body, but relative to the size of these vessels, it's hypovolemic. Yeah? Relative hypovolemia. So I have 3 problems. I have problem number 1, wide vessels. I have problem number 2, permeability, and I have problem number 3, relative hypovolemia. Awesome. So, how did I get there with sepsis? How did I get here in distributive shock? What is sepsis? Infection. So, what am I going to use to treat specifically the sepsis? Antibiotics. So, antibiotics is what this guy needs. Anaphylaxis, how did I get here? Massive histamine release from the antigen that is affecting the body. So what am I gonna do for this here? So epi-IM is first, right? And I don't care if your protocol says Benadryl first, and I hope to God it does not. It should be, as soon as you see signs of anaphylaxis, they get epi-IM, only in the vastus lateralis, never anywhere else, okay? It does not get absorbed. I can show you the study about that. It's gotta go in here.
Wait, can you say that again?
Yeah.
Start over and start?
Epi-IM, all ages, only ever goes in a vastus lateralis. It does not go in the deltoid. It does not go sub-Q. And because the study didn't include the glutes, it shouldn't go there either. But one could assume the big muscle here, this muscle's even bigger than this one. So one could assume the butt would be fine, but that wasn't in the study, okay? So right now, always, always, always only in the quad and as soon as possible, okay? So the sooner the better. So epi ASAP and repeated as needed. So if we're not totally turning the corner, they get another dose of epi. This is what's gonna save their life. How many minutes do we wait to give the second dose of epi? IM epi.
20.
What's your protocol say?
20.
20. So 10 to 15.
You sure about that?
That's really long, okay? So they can get worse at any time, so that's crazy. Epi ASAP and repeat it often, okay? Don't hold back on the epi. It's not going to hurt them if you overload them on epi. Maybe an older person who's got a really sick heart, that might be a little sketch, and I'd go more towards the 20, or be more cautious about giving the second dose. But everybody else, every 10 minutes is what I would be doing. If you don't give it, they can die. The reason that people die from anaphylaxis is because the nurses, the doctors, and the medics didn't give epi soon enough or often enough. I'm gonna say that again. The reason people die in anaphylaxis is a lack of epinephrine given by us. So when people die from anaphylaxis, we let them die, okay? Because we weren't aggressive with epi. Epi ASAP in the quad and repeat it often. Now the epi, in my opinion, or the way I remember this, epi-IM fixes this, okay? My swelling in the face, my trouble breathing, that kind of stuff. But when my swelling in my tongue, whatever. But IV epinephrine is fixing the cardiovascular collapse that might be coming. Epi-IM is not fixing this. This is IV epi that's gonna clamp this down. Does that make sense? That's not exactly how it works, but that's how I think about it, okay? So epi-IM for anaphylaxis, anaphylactic shock, epi-IM, and epi-IV. Fluids first, then epi-IV. Everybody good on that?
That's how our protocol's written.
Great. Where's Benadryl in there?
Before the FPIB.
Great. So what does Benadryl fix?
Histamine.
Okay, but what symptoms?
Itching.
Skin-related symptoms.
Skin-related symptoms only. So some people have Benadryl as their first med for anaphylaxis. No, thank you. Now you're fixing itching on a dead person. Okay? Not helpful. You could never give the Benadryl, and they're going to be okay. But the epi, this is anaphylaxis, okay? So in anaphylaxis treats the breathing and the cardiovascular collapse. Benadryl fixes the itching, the hives, the want to jump out of your skin, the itching, all that
It doesn't
stuff.
do anything for like angioedema.
No, epinephrine.
So I definitely gave a kid one time that was having angioedema. We started with the Benadryl and it went away.
Okay, fabulous, but that's not, I mean, it is an antihistamine, but if you have anaphylaxis, this is number one. Was your protocol written that way before, Benadryl first?
Well, it was actually a dude from North Tahoe. This kid has really bad allergies, and he just basically came and asked for an elixir. And the kid's mouth was all swollen. We gave him the elixir, and it went away within like 2 minutes.
Not even IM Benadryl.
Correct.
Well, that's very interesting.
Yeah.
I can't speak to that. All I can tell you is everything I've ever read, epi-IM for any facial swelling.
Or yeah, I think maybe
Related-
they gave him that beer, so I don't know. But we just gave him
Are
that.
these seasonal allergies?
I don't know. I mean, his whole lips and tongue was pretty swollen.
Is that all he had? Did he have skin stuff too?
Yeah, he had a little bit of
Okay.
redness.
In order to be anaphylaxis, you must have skin and A, B, or C. So I need to have a skin problem plus something with my airway, swelling, or something with my breathing, wheezes, or something with my circulation, dizziness, hypotension. So I need skin and A, B, or C. I have no idea where the brackets go for that. Okay, so that's anaphylaxis. So I can't speak to that. But everything is epi-IM. Then fluids, epi-IV for cardiovascular collapse. Somewhere in there, sure. When I had anaphylaxis, I could have cared less if somebody criped me. Did not care at all about my airway. This is me having the symptoms. All I cared about was the itching. I wanted to jump out of my body. And I was totally swollen in my face. I'll show you a picture of it. I was, like, my lips were massive. My tongue was massive. I had to swallow like this. Okay? Didn't care. I was like, cripe me. I don't give a shit. Please take the itching away. So Benadryl is useful for that. I'm not saying don't give it. I'm saying it really is secondary. Okay. All right. So epi-IM, and then IV fluids, and then epi as a vasopressor if I have cardiovascular collapse. And then, okay, let's come back to neurogenic shock. So here I am over here. And so I need to treat 1, 2, and 3. How do I treat those? So I gotta shrink it down, I gotta sew up the holes, and I gotta deal with this relative hypovolemia. Quick. Epi to shrink it. So I'm gonna shrink this down with epi-IV, right? We're at this point. So I'm shrinking it down with epi-IV, and as I shrink it down, I decrease some of that permeability. I'm decreasing that permeability as I bring the vessel down. What else? Fluid, exactly. I got to put fluid back into the system to help deal with this relative hypovolemia. So I'm pulling this down as I'm building this up. And then I get a pressure again. And then I get blood flow to the brain. Yes? Okay. So neurogenic shock. In neurogenic shock, so again, this is not how it works, but basically we got a heart, it's pumping around, there's lungs right here, and this is the flow around the body, okay? So in neurogenic shock, or actually, back it up. What if the body notices that the blood pressure is starting to drop, right? I got all these issues. The body clamps down to keep your blood pressure normal, right? What body system is doing that? Sympathetic nervous system, that's right. So the sympathetic nervous system is like, oh shit, something's going wrong. So it kicks out cortisol, it kicks out epinephrine, adrenaline, and boom, we start to shrink down our vessels, okay? So that's awesome. What else does it do to our heart rate? It notices not enough blood circulating to the brain. It increases the heart rate. Now I'm pumping I'm pumping blood more frequently. So I clamp down, I'm pumping blood more frequently. What about our respiratory rate? If it notices that you're starting to be a little hypoxic, which could be over here also, it's going to breathe faster to bring in more oxygen, so the blood that it sends up has oxygen in it. Okay, so the body knows what to do. Pulls blood from the periphery, all that kind of stuff. In neurogenic shock, two things had to have happened. I had to have a hit to the system, a hit to the spinal cord that is around the thoracic, T6, I think it is, I'm not sure, T6 and higher, essentially the nipple line, okay? So I have a hit to the spinal system at T6 or above, and that knocks out the sympathetic nervous system from that injury and below. So below that injury is the heart, okay? So where that's innervated. So if the heart is not getting the message to increase the blood pressure in a shock situation, it's not gonna increase the blood pressure. It's not gonna increase the heart rate. It's not gonna increase diaphragms down there too. It's not gonna increase my respiratory rate because there's no sympathetic nervous system working to do that. Therefore, in neurogenic shock, so hit to the system at T6 or above, I go into a shock state. What is the heart rate going to be? It should be high. I'm in shock, but what is it gonna be? Normal or low, even bradycardic, right? So I'm gonna have a low heart rate. What is my blood pressure gonna be? High? Low. I can't squeeze down. I have no squeezability. I don't have sympathetic nervous system sending blood back up to the core, okay? So definitely, I already moved to here in neurogenic shock because my blood pressure's in the toilet. I can't increase my respiratory rate, so I can't compensate. I can't fix any of this stuff, and so I'm right there. Now, if I can't pull blood to the periphery, am I gonna have mottled skin? So I can't pull blood to the periphery, so it's pooling down there. So I'm gonna be pink and warm down here because all my blood is down there, can't make it back up. So I'm pink and warm in the extremities, weird. I'm in shock, right? That doesn't make sense. Pink and warm, my heart rate is low, weird. My blood pressure's low, okay, shock, uncompensated or decompensated or hypotensive shock. Am I gonna have altered level of consciousness? For sure, right? I got all this going on. Am I gonna have shitty cap refill in my hands? Am I gonna be irritable? For sure, because I'm in shock. My blood pressure is gonna be in the toilet. The other thing that can happen is priapism, and that is just from the neurogenic, or from the injury to the spinal cord, okay? Now, in this, again, how this person presents is completely different than all these other shocks. So I have a T6 or above injury, I have low blood pressure, and I have low heart rate. Okay, so that's what goes, and pink warm extremities, lower extremities. This is still a distributive shock because I can't clamp down to improve my blood pressure. So it's still impermeable, relative hypovolemia, and wide floppy vessels. Questions on shock? Fabulous.